Good afternoon once again, and thank you for joining us. So before we begin, we'd like to say a few introductory remarks about Yetena Weg. Yetena Weg is registered in Pennsylvania, USA as a non-profit, and it's run entirely by volunteer members. We have more than 70 active volunteer members spanning across 5 different countries and counting more. And you can see some of our volunteers from the picture in the right upper hand. So our projects and engagements can be seen in 4 aspects. The first is our health promotion, which is done via discussions and articles regarding the health of the general public, health policy and its implementation. Our other engagement is our community engagement, where we organize blood drive, inclusivity, equity projects, and fundraising campaigns. Our third and one of our largest is our mentorship and skill sharing, where we provide direct mentorship, soft skill, career and professional development webinars for healthcare professionals. And the last is our medical education, which under it has the continued medical education and research and quality improvement projects. So these are our programs. And this is a slide showcasing the works done by our health promotion team, where they invite renowned consultant speakers and have a discussion regarding relevant topics to the general audience. And we also have podcasts that are shared directly via Telegram. Our other is our mentorship team, where we provide direct mentorship to healthcare professionals and workshops. Our other is our health advocacy, where we provide inclusivity in sign language training, inclusivity SRHR trainings, blood donation drives, and clubhouse discussions. So our other engagement or our other project is the Yetena Weg Health Article Writing Competition, which is done in collaboration with the Ethiopian Medical Students Association. The first round of health article writing competition was initially announced on September 2 of last year, and the winners were announced a couple of months back on October 19. Yetena Weg awarded pulse oximeter for the top 20 winners and Litmus stethoscope for the top 3 winners. And the top 5 winners also got internship opportunities at other partner institutions. This was the slide or the promotion poster we used to announce the top 20 speaker winners. And this is the top 20 winners with their respective prizes at EMA headquarters. Our other engagement is the Yetena Weg Research Fellowship in collaboration with the Anbessa Specialized Hospital, St. Paul and St. Paul Hospital Millennium Medical College. The first round has already concluded and the second round is well underway. When we come to our CME team, our CMEs are freely accessible, and for this, Yetena Weg partners with the Ethiopian Medical Association, with the Ethiopian Society of Cardiac Professionals, and the Ethiopian Society of Internal Medicine to provide continued training for healthcare professionals. We've had 39 CME webinars held in the previous year, and our average webinar attendees spanned from 150 to 200 healthcare professionals. And for these webinars, we invite renowned local and international speakers. And for 2025, we planned on having more than 30 webinars focusing on emergency, surgical and medical cases, ENT, pediatrics, OBGYN, and more. You can access our previous CME sessions by going to our Yetena Weg YouTube channel. And you can also get updates about our upcoming CMEs by joining Yetena Weg's Telegram channel for healthcare professionals or by following our social media posts, the links of which will be pasted in the chat box below. So in order to get the best experience in the webinar, we urge you to send your questions to the Q&A or to the chat box. At the end of the webinar, your questions will be addressed by our guest speaker accordingly. And in order to get your CU certificates, you must fulfill the following set of criteria. The first is attend the whole session virtually. And the second is fill in the Google form for personal detail and attendance. Please take your time to provide your correct credentials to avoid any issues with certification. And the third and last is get 50% and above on the post-webinar quiz. So you will be able to see your results right away, but your certificates will be delivered in a 2 weeks time frame to the email address you've provided. So we ask that you wait patiently in the meantime. This is all about Yetena Weg. So this webinar today is a collaborative effort between Yetena Weg's CME and Disability Advocacy team. Dr. Joe Kebet from Disability Advocacy team is here with us and will briefly introduce us to our Disability Advocacy team's works, and we'll proceed with the webinar. Thank you.
Thank you. So under health advocacy, we have a disability inclusion team. Our team has been active for almost 3 years and was able to engage in a wide range of initiatives aimed at promoting disability awareness and inclusion. So far, the team was able to increase awareness in the society about autism spectrum disorder, Down syndrome, and intellectual disability. The team was also able to collab with other institutions like Taki Paperback to train deaf women on breast cancer, cervical cancer, and infertility. In our disability inclusion team is committed to foster a society and a healthcare system where disability are fully understood, respected, and embraced. Today, together with CME team, we have brought you a special guest, Dr. Yerusalem. I hope you enjoyed the session.
Okay, thank you, Dr. Jokebed. So we'll introduce our guest speaker today. Our guest speaker today, Dr. Eyerusalem, is a neurosurgeon and an assistant professor at St. Paul's Hospital Millennium Medical College. She earned her MD from St. Paul Hospital Millennium Medical College, where she graduated as the highest scoring female graduate in her class. She then went on to complete her neurosurgery residency training at the same institution, receiving advanced training in brain trauma, pediatric neurosurgery, and brain tumors. Following her training, Dr. Eyerusalem built a strong academic and clinical career as a neurosurgeon with growing expertise in advanced surgical techniques, multidisciplinary care, and mentorship. She has developed an active portfolio of peer-reviewed publications and international collaborations, reflecting her commitment to research and academic excellence. Dr. Eyerusalem is also a passionate advocate for neurosurgical equity in Ethiopia and globally, contributing to capacity building and educational initiatives. She serves on the executive committee of the Ethiopian Society of Ethiopian Neurological Surgery Professionals and is the East African representative to the Young Continental Association of African Neurosurgical Society. In addition to all of this, she has also co-founded Microneurosurgery Ethiopia, a YouTube-based platform dedicated to promoting low-cost neurosurgical training. Dr. Yerusalem, it's an honor and a privilege to have you with us. Thank you, and please proceed.
All right. Thank you so much, Yetena Weg team, especially Dr. Joki, for inviting me here. And I think the discussion point itself, the disability, it's a very important topic we need to discuss on quite regularly, and we need to have a very good knowledge on. Of course, brain and spine trauma, it's not a very short topic, but I'll try to narrow down the things that are related with disability, specifically pertaining to disability in this presentation. And I'm so thankful for you guys for inviting me here. So this is going to be our roadmap for the webinar today. I'll be talking about the global burden of TBI and all the neurotraumas, what does it mean to care for this TBI and spine trauma patients in the primary care setting. I am assuming these are the centers that do not have a neurosurgery capacity, because right now in Ethiopia, I know that there are, I think, about 21 centers that are currently providing neurosurgical care, unlike all the other healthcare posts, healthcare and primary hospitals. I know there are a lot of hospitals that do not have the neurosurgeons and don't provide those neurosurgical cares. So how do we do the brain injury assessment? Most of my talks are geared into trying to show how we can prevent this disability when it comes to TBI and spine injury. And I'll be finalizing some of the important topics, some of the important points later on. So to start with, neurotrauma, specifically traumatic brain injury, is one of those important topics we need to discuss. Why? Because of the burden we have. For those interested, you can review this paper about the global burden of traumatic brain injury. You can find it if you search this paper. And it's a leading cause of death and topic of the day, disability, in especially a young, productive population of our country and our world. And 90% of this burden is in the LMIC, that is low middle income countries. Our country, Ethiopia, is also included in this low and middle income countries. So it's one of those important topics we need to discuss about. And we know that the most common causes we see in our country are road traffic accidents. So preventive method, preventive things we need to do to prevent this traumatic brain injury need to be implemented. That's one thing we need to talk about. But once it occurs, what can we do to prevent this disability is going to be the talk of our day. The second cause of this traumatic brain injury and traumatic spine injury is assaults. And in our country, most of our settings, what we see next to road traffic accidents is stone injuries or stick injuries that are when there is war, patients will come with penetrating TBI or penetrating spine injury that are caused by gunshot wounds, and that is also followed by falls. And to give you a little bit perspective, this is the number taken from this paper. There were around 20 million incidents of traumatic brain injury in the year 2021. And from this, 5.4 million people had year lost to disability. That means these people lost years of their healthy life for this because of their disability because of this traumatic brain injury. So this is why we need to discuss traumatic brain injury, traumatic spine injury. I'll stick to the basics. So what happens what happens in traumatic brain injury that results in disability? The first one is whether it's a mild TBI. It can occur in mild TBI patients, but it's most common in moderate and severe TBI patients. This patient will have problem with their cognition, problem with their memory, problem with their attention, problem with their executive function. This is one of the topics we don't usually talk about, but we need to talk about this, and we need to link these patients into a multidisciplinary team that takes care of this cognition issue. The other important disability we need to talk about is chronic pain. This is important, especially in patients with spine injury. They will have multiple types of chronic pain that will result after traumatic spine injury. This is one of the disability we need to talk about. Another important thing, one of the obvious things that happens is permanent paralysis, especially in patients with area A spinal injury, in which there is a complete loss of motor function. That is also compounded with patients who have chronic spinal instability, patients who develop deformity after they develop their spine injury. Another important disability we need to talk about is post-traumatic epilepsy. These patients with traumatic brain injury, they tend to have a higher chance, a higher risk of developing post-traumatic epilepsy. And that is why, to prevent the early post-traumatic seizures, we provide them with prophylactic anticonvulsant therapy. And the other obvious injury would be visual and hearing deficit that will result in disability. Moving on, so when should we intervene and what can we actually do to prevent this disability? So to divide traumatic brain injury, for example, let's take traumatic brain injury. We divide it into primary and secondary injury. The primary injury, it divides the patient into those who can survive and those who can't survive. So basically, we can't really do anything about the primary traumatic brain injury, but our workhorse, our majority of efforts would be relying on preventing and managing the secondary brain injury. So for this, we have this rule: recognize the injury early, identify the trauma, the signs, the symptoms early, stabilize them immediately. As a neurosurgeon, as much as I want to say the brain is the first thing that needs to take care of, it's always the airway. I'll be repeating this idea over again. Airway, breathing, circulation, following the ATLS guideline, it's always important. We need to be very mindful of that. The 4 to 6 hour golden period I brought here is to talk about the secondary brain injury. Not necessarily the brain will tolerate hours injury, because your brain would be irreversibly injured if there is some sort of hypoxia or anoxia for more than 3 to 5 minutes. That's it for the brain. But the secondary injuries we are going to discuss about, they tend to do their work in the first 4 to 6 hours. So those times, they actually require our effort in managing those patients. So we need to avoid errors. We need to assess this patient early. And if you don't have that setup in which the patient can't be handled, can't be managed, whether it's surgically or medically, they have to be referred early. So the motto becomes you recognize, you stabilize, you do your ABC, and then refer them if the setup does not allow you to manage those things. So what exactly traumatic brain injury? When some sort of external mechanical forces apply to your brain, that results in a pathology that is called a traumatic brain injury. It can be a structural pathology. It can be, you see these physiological disruptions specifically in patients with diffuse axonal injuries, in which you might not even find these imaging pathologies, but you would definitely see a patient in a coma. So these are the definition and what happens when patients have traumatic brain injury. So for us to be able to manage this patient, we need to classify them into a smaller group that we can handle and we can have some sort of guideline towards, and we can handle those patients in those specific categories. And there are a lot of classification. However, we'll be focusing on one that can be used easily. This is majorly based on Glasgow Coma Scale. This is the basics of neurosurgery in general. Whether you're evaluating any type of trauma, tumor, anything patients, you need to evaluate their GCS. This is basics. Basics are basics for everything. And specifically for trauma patients, GCS is important because it helps us classify patients into mild, which is GCS into 15, moderate patient with GCS between 9 to 12, and severe patients between GCS less than 8. So, and the other way of classifying this would be blunt injury. These are the pictures you see here, whether you're hit by a stick, a ball, or you went ahead and hit your head on the wall. These are blunt injuries. And this picture you see in the middle, it's a picture of Phineas gauge. It has resulted in a lot of interesting conversation around this, but one important thing that differentiates blunt injury from penetrating injury is the disruption of the dura. So if the dura is disrupted, whatever injury, it's penetrating. If not, it's blunt. And blunt injuries are separated because they are a mix of everything. They might have a penetrating, they might have a blunt, they will have some sort of pressure injury to the brain as well. So they will have a complex type of injury, so they are separately classified. And these patients tend to have a higher risk of sudden increased ICP because of the injury type, which is a blast injury. Moving on. So, initial assessment. Again, we go back to the ATA list. How is the airway? Plus to the airway, specifically, we need to care for the cervical spine too. It has to be stabilized. I will be saying this over and over again. The cervical spine needs to be protected, stabilized, unless you rule out there is no injury, especially in a patient where there is some sort of loss of consciousness or confusion or any type of change in mentation. It has to be stabilized always. We see a lot of deficiencies regarding this when patients come to our centers, whether it's because of lack of scholars or anything, or lack of knowledge for that matter, but this is a very basic thing. Why do we say this is a very basic thing? In patients with traumatic brain injury, mortality doubles if the patient has hypoxia, and it triples if the patient has hypoxia with hypotension. So after airway, making sure your airway is clear, making sure your patient is ventilated and oxygenated well, your circulation is also matters a lot, because you need to maintain an adequate cerebral perfusion pressure for the patient to actually survive, for patient to have a very good autoregulation of their intracranial pressure. Then you come and evaluate the GCS score and the pupillary exam. So on your pupillary exam, what do you actually see is, specifically in trauma patient, you're looking for a blown out pupil. Blown out pupil means one-sided dilated and fixed, and the other side it might be normal or it might be mid-sized. This happens because of increased ICP. That increased ICP results in compression of cranial number 3, and that results in a blown out pupil, because a cranial nerve number 3 or oculomotor nerve, so it's outside is where the parasympathetic nerves are located. So they are easily compressed whenever there is some sort of external compression. Maybe one example for you would be an aneurysm patient with a large aneurysm. They're awake, they're fine, but when you check their pupil, one side is blown out. So that is one important thing we need to do during trauma patient, and that is followed by exposure. This goes to, now you can check the spine, you can check other organs. So this is basic. It's basic, it's important for everything you do in traumatic and a spine injury. Now you evaluated them, you know what they have. The next step would be, who should we image? Who should we send for imaging? One thing very important is, right now in this day and age, X-ray has become close to useless. That's how I would describe it. It's always better to get a brain CT scan. X-ray might help you, one, in localizing some sort of foreign bodies. Sometimes in previous days, we used to see midline shift on X-rays. But now, with the advent of CT scan, it's basically pointless to do X-ray. So go for CT scan. Who are the patients that need this CT scan? Patient who has loss of consciousness, patient who have amnesia. This is from NICE guidelines, by the way. Patient who have severe headache, patient who have vomiting. A special focus for patients with age greater than 65, because a minor injury would result in some sort of injury in these patients. And dangerous mechanisms. Dangerous mechanisms, again, in patients with age greater than 65, it becomes even a ground level fall would be a dangerous mechanism for these patients. But for others, for example, fall from 3 meters, patients who are ejected from vehicles, or pedestrians that were hit by a car, or there is an injury and somebody else died, that tells you about the severity of the injury. These are the things we need to consider. And even if the patients are fine, you have to scan these patients. The other is patient who already have seizures, patient who is focal neurologic deficit, patient who you suspect skull fractures. These are obvious indications, right? And coming to one of those most important symptoms and signs that need urgent CT scan. You see these patients, whether you see them for the first time or they were in the wards and you've been following them and you see these things, you have to image them. It has to be an urgent CT scan. Patient who had 2 GCS decline. If their GCS declines by more than 2 or more than 2 from your previous score, you have to get a CT urgently. Patient who have repetitive vomiting, patient who develop a new focal neurologic deficit, patient who develops while you are on follow-up, and new post-traumatic seizures, patient who have worsening of headaches. These are the red flag signs we tell our patients, once they go home, you need to come back if you have this. And we need to follow our patients as well when they are in the wards for follow-up or anything. And if they develop severe worsening of headache, you have to scan them again. Signs of skull fractures, they have to be scanned. Any change in pupillary size, they have to be scanned, specifically when they have blown out pupil. So this picture you see here, the famous photo you see, you have a raccoon eye, in which there is a redness around the eye that tells you there is some sort of basal skull fracture. You have a battle sign, again, some sort of ecchymosis at the back of your ear. Again, that also tells you a basal skull fracture, specifically the masseter region. So you did your evaluation, you saw the patient, you decided who need to get a CT, and you took the CT. Now, what do you expect to see on those CT, and who are the patients who actually need urgent surgical intervention that you need to send them very fast to a setup where there is a surgical management? So the first thing, amongst all of the traumatic brain injury CT findings, acute epidural hematoma is one of the most, one, rewarding, two, if you don't do something, they will deteriorate so fast you can't do anything later on. So your management should be very fast. You need to recognize it very well, and then you have to operate on them very early. So what is the CT finding of epidural hematoma? As you know, because of the sutures, they can't expand that much, so they create this lenticular or biconvex type of shape. You can see here it's the picture in the middle. It's the picture in the middle. You can see it here. So they will have this biconvex type of hyperdense or whitish finding on your CT scan, and you have to know how to measure this volume so that you can say, for example, patient who has a 40 cc epidural, you have to be very fast when you try to manage them. So the way we measure the volume would be you measure the anterior-posterior, the mediolateral, and then the superior-inferior direction. All the largest measurement size will be taken. You multiply them and divide them by 2. That will give you your volume. So if their volume is greater than 30, and based on this, the picture you see on the far right, you also measure the midline. You use normally the black thing you see in the middle, that's the ventricle. Sorry, guys. And the white stuff that's dividing the ventricle, that's septum pellucidum. So you use that as a landmark to try and measure the midline. The way you use the midline is you measure this. Usually you try to go and find the crista galli, that tells you where the midline is, and you try to go posteriorly. When you follow the falx, the white thing in the middle, that's basically the falx, the final attachment at the back. The falx attachment, you can use it also as anterior and then posterior landmark for you to use as a easy way to measure your midline shift. And then you measure the length between the septum pellucidum and the line you just drew from anterior to posterior. And based on that measurement, if that measurement is greater than 5 millimeter, for anything, whether it's a contusion you see, whether it's a subdural, whether it is diffuse brain edema, it's always a surgical indication. So if you want to use it as an easy way to memorize things. So 5 millimeter midline shift is a very important thing we need to know. That tells you that the brain is under some sort of strain. It's being pushed to the other side. So it's always a surgical indication, specifically in epidural hematoma patient. And in epidural hematoma patient, the medial lateral thickness you measure, if it's greater than 15 millimeter or 1.5 centimeter, that's also an indication. So why am I telling you this? Because you need to identify this patient and send them to neurosurgery as soon as possible. If you don't intervene early, these patients are going to die. Or by the time they are being operated on, they have already developed disability. That is what we are trying to prevent right now, right? The other important thing is acute subdural hematoma. That's also another important thing that needs to be operated right away. So they usually have this, I am showing you the image on your far right. So they will have this precentric type of shape. An acute bleed is hyperdense or white on a CT scan. And you would see that, again, you measure the mediolateral thickness. If that thickness is greater than 1 centimeter, your midline shift is greater than 5 millimeters, these patients need to be operated as soon as possible based on their clinical finding. Another finding you would see is brain contusions. These are tiny white hyperdensities on a CT scan. Usually you would see them either in the frontal region or in the temporal region, and usually they are very small. They might not need any intervention, but sometimes they will coalesce. We call it blooming. One of the reasons we need to follow patients for 24 hours after they are admitted is that patients with small contusions, they will coalesce and they will bloom, and that will result in a mass effect, and later on those patients might deteriorate and need intervention. So these are also very important, especially if they are bilateral frontal contusions, and patients are GCS 14 or so in early 24 hours. You have to observe those patients and follow them. And with any deterioration, get your CT scan and see what is happening. And then you check the basal cisterns. So basal cisterns are the CSF collected areas. Very sorry. I think I have a picture here. So the picture you see on your far left, on the measurement area. In the measurement area, you would see these black things. I think I'll show you. Yes. Hopefully you guys can see this. So what I'm trying to show you is these black stuffs you see here, those are cisterns. And the basal cisterns are taken as a way of determining if that patient has increased intracranial pressure or not. Because In those patients who have already increased intracranial pressure, they will have this effaced, that means completely obliterated basal systems. You wouldn't see this black stuff on CT scan. So in patients, especially with contusions, frontal contusions, if you see these basal systems being completely effaced, they have to be operated in some sort of way. So they have to be seen by a neurosurgeon, and they might need, for example, if they have bifrontal contusions, they might need bifrontal decompression. If it is only on one side, they might need one side decompression. So that's a very important thing to know. And the bigger size of this contusion would be intraparenchymal hemorrhage or ICH. That also needs to be taken care of. Another thing we usually operate on, even if it's not as fast as the acute epidural and acute subdural, is the skull base fractures or depressed skull fractures. So any compound depressed skull fracture with signs of some sort of dural breach has to be operated. The dura has to be closed. So what are those signs of dural breach? You say pneumocephalus, contusion. Pneumocephalus is air in the intracranial space. Contusion is, earlier I have showed you the white minute hyperdensities you see on the brain. That's called contusion. So they also need to be operated. So compound depressed skull fractures, they are an indication. When it's closed, it becomes a nuanced decision. The other important thing is patients with diffuse brain edema. I don't know if you can see it very well on this image. Patients with diffuse brain edema on a CT scan, what you would see is normally you have a sulci, a gyri, you'd have this squiggly type of safe spaces, but you would lose all of that, and the brain just becomes filled. The brain fills up the intracranial cavity. You don't see any cell size or the basal systems. They will be filled, and those imaging findings will tell you that that patient might have a diffuse brain edema. So these are important things we need to figure out so that we can send these patients for management. So as someone who is in a primary care, what can you do? Always maintain the saturation of those patients above 90. 94 says the NICE guideline, and the systolic blood pressure has to be kept above 90. Other guidelines say above 100 or 110. That's very important. Elevating the head, it's very important. It has to be elevated 30 degrees. That is one way of managing the increased ICP. These patients, we need to avoid any sort of overhydration, and we need to control their seizure. If they already have seizures, it has to be managed. Patients in our country, I don't think we have levetiracetam everywhere, so we need to start them on phenytoin. But there are patients who need prophylactic phenytoin, patients who already have this hematomas, contusions, acute epidural, subdural hematoma, compound skull fracture, any sort of injury to the brain, they have to be put on prophylactic anticonvulsant, and they need to be put on a pain management as well. So when should we transfer them to neurosurgery? I have shown you the CT scan findings. All those CT scan findings, all those indications they have done, send them directly to neurosurgery. They have to be operated. So that's what I mean by any intracranial hematoma. Patient with GCS less than 13 who already has those CT scan findings, penetrating TBI, one way or another, they have to be debrided, so they have to be sent to neurosurgery. This GCS drop, it's trying to show you the urgency of it all, and they need to be scanned and find out what kind of intracranial space occupying lesions they have, and then they can be operated. This is for spine, we can skip that. And then moving on, that's all about traumatic brain injury, and especially what we can do about traumatic brain injury. I'll come back to it later on. When you get a patient with spine injury, what makes you suspect there is some sort of spine injury? First thing, any sort of midline spine tenderness on palpation, any patient with neurologic deficit, weakness, numbness, you have to suspect spine injury. Any patient with they have trauma, they come to you, you see any neurologic deficit, you have to suspect. The other thing is bowel and bladder control issue and high risk mechanisms I mentioned earlier. And if patients already have distracting pain, you need to be very cognizant of the spine as well. Even if they are complaining more about their femoral fracture, you shouldn't forget the spine injury. And in patients with elderly, you have to always be in high alert when it comes to traumatic brain as well as spine injury. So we have to suspect those. Moving on. And then what can you do to actually prevent disability and later on deterioration for this patient? Always immobilize, put them on a spine board, especially if you have any suspicion of spine trauma, put them on a spine board, fix that spine, get your imaging, and then rule it out. If you can't rule it out, always put them on stabilization. So I keep coming back to this, trying to prevent the neck movement. It's because I have seen a lot of patients who came to tertiary center I work at without neck collar while they have spine trauma. So I am trying to emphasize more and more on that because that's a very basic thing we can do to prevent further injury. Any patient with suspected spine trauma, when you roll them over, you have to use 4 people, 3 to 4 people, and you need to log roll them. That's very important. That's to prevent any sort of, if they have any sort of instability, that's to prevent that instability to move even further and result in some sort of spine injury. Another important caveat is in a patient with suspected spine injury, the mean arterial pressure, it should be higher than the normal expectation we have. So the mean arterial pressure should be greater than 85, unlike the other injuries. So this is also very important thing to consider. And if you want to see more on this, you can see the American Association of Neurological Surgeons with Congress of Neurological Surgeons. They have this guideline coming up almost every year. You can read on that. So, you know, your patient might have those injury, specifically cervical injury. Who are those patients who need to get imaging or who you can rule out? The first thing, patient has posterior midline cervical tenderness, you have to image them. Patient is intoxicated, you need to get brain and cervical CT as well. And patients, they are confused. That goes again with the intoxication. Patient has some sort of focal neurologic deficit. Again, you need to get those imagings. And those who have pain, distracting injuries like extremity fractures, you also need to be very cognizant of this injury as well. For thoracolumbar CT, patients, if they have some sort of back pain, specifically complaining to specific sites, and again, high risk of mechanism of injury, I mentioned earlier, and you would find an abnormal neurological exam. They would have lower extremity weakness, and those patients need also to get a thoracolumbar CT scan. If they have a complaint above, which is in the change in mentation, you need to get a brain CT, and then you also need to get the thoracolumbar CT. In a spine injury patient, what are the things you shouldn't do? You shouldn't rely on X-rays. X-rays, they might be useful in some of the things, for example, post-op follow-up or things like that. We shouldn't rely on X-rays to rule out spine injury. It has to be a CT scan. So CT should be done. The other thing is, you suspect those injuries, they have to be referred earlier. And if you suspect spine injury, it is unstable by nature until it's clear. So these are important things we need to rely on to prevent disability. I have tried to come up with some of the imagings in spine. For example, one of the most common injuries we see, it's called burst fracture. This is burst fracture. So there is this 3-column theory in which it divides the vertebral body into anterior half and posterior half. Anything posterior to it, like the posterior to the vertebral body or the posterior longitudinal ligament, it is said to be the posterior element. So you have anterior, the anterior half, middle, the middle half, or the posterior half of the vertebral body. And then anything behind this, it's a posterior. So a fracture, a compression type of fracture that is involving both the anterior and the middle column, that is called a burst fracture. This is one of the most common type of thoracolumbar injury that needs surgery and that shouldn't be ignored. So this is one example. The other example would be, it would be an extended discussion, but there are different set of classification for this. One of the things we use is called AO classification, but I won't be going in detail on that. This example I have brought you here, it's called chance fracture. This is when you have a fracture that goes through all of the elements I discussed earlier. If it is going through directly only the bony segment, that tends to be stable. However, if this transverse type of fracture involves the ligaments, that makes things unstable. So this patient have to be evaluated by someone who is capable of operating them, neurosurgeons or spine surgeons. So this is one of the example I'm trying to bring it to you. Another common fracture we see is odontoid fracture. As you know, C2, C1, C2 area is a very special region with a lot of movements. One of the common injuries we see is so you have C2 body, these are the facets, this is the odontoid itself. When you have some sort of fracture in that odontoid fracture, we call it odontoid fracture, obviously. But this fracture specifically, the one that's going like just below the odontoid, this one, we call it type 2. That's very important to manage surgically. So those are the things I want to mention. Another thing is hangman fracture. Hangman fracture is another C2 level fracture in which the fracture goes through bilateral pars. Pars is where, if you can see here, this is the superior articular facet. This is the inferior articular facet in which C2 articulates with C3. This is C2 articulates with C1. And this place is called pars. And when there is bilateral pars fracture, that's called hangman fracture. Another thing that might need surgery. Another most important thing, especially that has a very determinant, the fact that you referred those patients early, the fact that you reduced those patients early, resulting in less disability and better outcome. This is bilateral locked facet. So this normal part you see, it's called shingled pattern, in which the facets are, they are, how do you say it? They are ተደራርበው ነው ያሉት. Amharic is better here. So that kind of pattern, that shingled pattern, would be lost, and this facet would come in, jump in front of the facet below, and that is called locked facet. These patients, they have to be reduced early, they have to be fused early. So these are one of important fractures that need to be referred very early on. So another important thing we need to consider during the spinal cord injury is the critical spinal cord syndromes. We know the central cord syndrome usually occurs in the cervical region. It's not in a trauma patient. Usually you see it in a patient with syrinx, in which the upper body or upper limbs are disproportionately affected by this than the lower extremity. So this is called central cord syndrome. This is to refresh your memory. And another one would be the anterior cord syndrome, in which there is some sort of injury to the anterior spinal artery, and almost the anterior 2/3 of the spinal cord would be lost. So that would result in patients losing their motor, their pain and temperature. The only thing that would survive would be the dorsal column function, and that is one of the syndromes we need to know about. In trauma patients, one of the good outcomes are seen in patients with Brown-Séquard syndrome, in which you would see half of the motor and position would be gone ipsilaterally, and the other half, contralateral pain and temperature loss, would happen. And these patients tend to recover very fast. So these are one of the good outcome spine injury patients. Caudal equina syndrome becomes when there is some sort of injury. I would show you maybe one image. So this image you see here, this is L2 vertebral body burst fracture. These are one of the fractures that will result in caudal equina syndrome, in which patients would have saddle anesthesia around their groin region. They will have urinary retention. They will have asymmetric leg weakness. And this patient, they have to be decompressed very early, maybe in the first 24 hours. The maximum would be 72 hours. If you get them after that, the likelihood that they would recover function is very low. So they have to be managed early on. So at the end of the day, what becomes the point of discussion is you can't do anything about the primary injury, whether you call it a spine or traumatic brain injury. What you can do is the secondary injuries that happen after the patients develop that trauma. And I will be telling you three points. In secondary brain injury, take care of the oxygen, take care of the blood pressure, and then take care of the carbon dioxide, because in patients with hypercapnia or hypocapnia, you need to maintain it somewhere in 35 and 45. If you have end-tidal carbon dioxide measurement, that would be very easy for you. This is done usually in the ORs, but this is important, marker for brain injury. So your oxygen, your blood pressure, and maintaining normal capnia would be three important things we do in preventing secondary brain injury and disability in traumatic brain injury patients. When it comes to spine patients, again, the blood pressure becomes a very important factor, especially we need to maintain the mean arterial pressure above 85, unlike the traumatic brain injury patients. And they have to be immobilized. You need to think they are unstable unless you rule out the injury, and they have to be referred to specialized care as soon as possible. All of this is being done to prevent secondary injury and further disability. What can you start when you come to brain injury? What can you start on a primary level? Is you can start them on antiepileptics, those who need prophylaxis or who already have seizure. You can start them on analgesics. The best analgesic to start when it comes to their side effect is paracetamol. You can start them on opioid as well, but that might mask your neurologic examination. So if the patient tolerates it with paracetamol, it's better to stick with that. And if you suspect the patient has increased ICP, you can start them on mannitol prior to sending them to the specialized center. And a spine injury patient, again, manage the pain, steroid, no need for them. We used to give steroids, and there were some guidelines they used to prescribe steroids for spine injury, but now we shouldn't start steroids. Steroid is a no-no because of its secondary complications that will worsen the outcome later on. So at the end of the day, what you're trying to do is you want to control the symptom without compromising the neurologic assessment. That's what you want to do. So today's discussion is basically about disability. And when are the times that disability would happen because of neurotrauma, and what are the things that we didn't do or we do to facilitate this? The first is missing the early red flag signs. So patient comes to you with traumatic brain injury or traumatic spine injury. If you don't recognize it earlier, that's one point for that patient to develop mortality and later on disability. That's one thing to consider. The other thing is poor initial stabilization. ATLS, it works for everything. I keep coming back to this again. Stabilize the airway, stabilize the spine, stabilize the breathing, circulation. That's very important for everything. And then image them as soon as possible. Lack of imaging, lack of diagnosis of those important entities, again, it contributes to disability. The other important thing is now you already know that patient needs surgery, but for whatever reason, you couldn't get that neurosurgical care. That also contributes to disability. And then what we usually struggle with, whether it's trauma patient or other neurosurgical patients, is you do the surgery, whatever can be done, whether you did early stabilization, early imaging, early neurosurgical care, and then the patient needs to be sent to rehabilitation center. We need to have a very good rehabilitation. So patient not having that adequate early multidisciplinary rehabilitation, again, that contributes to disability. So these are the areas we need to tackle if we want to work on disability or preventing disabilities that comes with neurotrauma. So now we have touched on everything. What kind of surgery can we do? What kind of medical management can we do? Now we move on to the important step that shouldn't be missed in any patient. Early rehabilitation, especially in a spine patient, preventing bed sore. Once they are operated or managed in whatever way, regular repositioning, checking their ski, it's a very important thing. Because what ends up happening is, let's say a patient needed surgery, we operated on him, and then he was discharged. For some reasons, the patient or the family did not check the bed sore, or they had some sort of bed sore. That bed sore progresses, it becomes a source of infection. That patient dies of sepsis. This is a very sad thing we see almost every day. So that's a very important thing to check. Another focus of sepsis becomes the bladder. Patients, they're not voiding timely, their catheter care is not very good. So we need to focus on that catheter care, changing it every 2 weeks, following them for any signs of infection. It becomes a very, very important thing, as well as the bowel management. Especially in spine injury patient, thromboprophylaxis. I don't know how many of you have the access for this graduated compression stocking or other compression devices. That's a very easy way of providing thromboprophylaxis, but the mainstay of way for us to provide thromboprophylaxis becomes the drugs. We use either the low molecular weight heparin, enoxaparin, rivaroxaparin, the other medications we use, they're very important. And even if the patient is operated, they have to be started within 48 hours and it has to be continued. Another important thing, we need to have a physiotherapy, especially in a spine patient and a severe and moderate TBI patient. These are very important. As much as the surgery is very important, these things I'm discussing on this slide, they are even more crucial to recovery of these patients and preventing disability. Again, especially in spine trauma patients, they tend to be depressed, they will have some sort of psychological issues, so managing that would be also very important. So at the end of the day, any type of neurotrauma, it needs a multidisciplinary team. It needs the neurosurgeons, it needs the physical therapists, it majorly needs the nursing care, the anesthesia, the emergency, everything. It has to be coordinated. The outpatient care, the inpatient care, it has to be coordinated for us to see a better outcome. So these are the early rehabilitations. What about the long-term disability that comes from traumatic brain injury? Again, earlier we mentioned there would be some sort of cognitive abnormality. So that needs to be picked and also managed. Patient would tend to have sleep problems. Patient will have some sort of chronic pain, for example, headache, other back pain. They need to be managed. Patient would have post-traumatic epilepsy. Again, that needs to be managed as well. Vision, hearing abnormality, if they have them, that needs to be managed as well. So at the end of the day, timely management of everything, early stabilization, focusing on rehabilitation, and then later on, managing the long-term disability would become a very important thing. Maybe one part that would be ignored is patients with GCS 15 who are initially fine, they tend to be ignored, but those patients should not be ignored. They should be followed. Let's say a patient of GCS 15 came to you, he has a minor contusion in the frontal or temporal region. You're following them, but they shouldn't be forgotten. Sometimes a mild injury patient, we tend to push them around, but that shouldn't be done. And especially if they have repeated vomiting, they develop some sort of confusion, they need to be evaluated early, especially patients with bilateral frontal contusion, because all of a sudden they will deteriorate and they become those patients who talk and die. So even if initially they were mild TBI patients, you have to follow them and you need to take care of them. That's one of the warning points I wanted to bring right now. And when it comes to cervical spine injury, I think we have mentioned a lot of this early on. So I'll be jumping to, we have the 10 commandments. So I have seen somebody do this for a spine and brain injury, so I brought them here. When you talk about primary care in brain and traumatic spine injury, airway and spine, take care of it. Oxygenation, very important. Maintaining the blood pressure above 90 systolic, very important. Checking their GCS, especially patients with moderate and severe TBI, they have to be checked regularly. That's very important. When you come to spine injury, immobilize all suspected injuries, image them when you find any red flag. And in patients right now, we have a lot of motorbike rides and delivery systems, right? In those patients, we should immobilize before removing the helmet. That's important thing. There is no place for steroid in spine injury. If you don't have the service, refer these patients very early on and document everything for better communication with everyone. So, final message, neurotrauma, it's very time sensitive. The primary care, the primary decision you do, it's what stands between someone who lives, someone who walks, someone who recovers, versus someone who doesn't. So this is a very short and concise presentation on those. Thank you so much, everyone, for listening. I'd be accepting comments and questions. Thank you so much, guys.
Thank you very much, Doctor, for that insightful and highly practical lecture. So your expertise has enriched our understanding of the primary care approach to brain and spine injuries. Having said that, we'll directly proceed to the Q&A. Since our guest speaker has another commitment, we'll only be taking a few questions. So we urge everyone to send their questions to the chat box or to the Q&A. My co-host, Dr. Asrafil, will proceed with the Q&A. Thank you.
Okay, hello everyone. Hope you had a very interesting session with Dr. Eyerusalem. I was enjoying every bit of it. We have a few interesting questions, and I will start with the first one. The first question reads, what methods can we use for cervical spine protection in the absence of neck collar?
Right. That's a very good question. So right now, everything you talk about it as if you are in a very good setup that you have a cooler, you have everything at hand. But sometimes you might not have it. The easiest thing I have seen being done is there are hard, what do you call it, boxes like cartoon. We call them in white or whatever we use. We can use those hard cartoons and stabilize them. And we can add 2 bags of saline, right and left, and then try to stabilize those patients. So you can use hard box with saline. That's one way of using it. So you have to stabilize it on the forehead, and you have to stabilize it here as well. So that's one thing that would be available everywhere. Or we also, I don't know if you have hard boxes. So the flat board, sometimes the flat board would also have these 2 bars that would stabilize the spine itself. So if you have that, you can use that as well. Or if you have sandbag, I don't know, something strong that can stabilize the spine like this, you can use whatever you have at hand. Cartoon, sandboard, saline with fixation to the forehead. Good work.
Thank you, Doctor. The second question reads, indication for prophylactic anti-seizure in traumatic brain injury patients.
That's actually a very good question. So there are around 7 or 8. I'll try to mention those. So the first one is if you have a patient with epidural, subdural hematoma, contusions especially. Contusions are a very high risk for seizure. Patients with penetrating brain injury, patients with compound skull fracture, again, they tend to have contusions with them. If they don't, you don't necessarily need to give them, but if they have contusion, they have to be started. Patients who were alcoholic and who had that excessive alcohol consumption in the past 24 hours. Alcoholic patients, they also tend to have a higher risk of seizure. Patients who already have seizure, like previously they were diagnosed epileptic patients, they need to be put on anticonvulsant as well. So I think I've mentioned those.
Okay, doctor. The third question is, which subtle signs of brain or spine injury are the most commonly missed?
Okay, that's actually a very good question. So, subtle signs, specifically when it comes to my experience, patients with bilateral frontal contusions, they're usually fine. What you need to do is follow them consecutively, because at some point they will just drop dead or they will deteriorate. So they have to follow them for 24 hours. They will show you when they deteriorate if you follow them enough. Otherwise, they will show you. They will have worsening of headache. Sometimes that might be ignored. They will have vomiting. You might ignore that as well, but you shouldn't, especially in patients who has some sort of CT finding. Those neurologic deficits, they are obvious, but patients with bilateral frontal contusions, they have to be followed. At the end of the day, if you follow them, you will catch them. If you don't, you don't. I'm trying to mention that multiple times because I had one experience when I was a resident. We had a patient with bilateral frontal contusion. We thought he was fine. GCS was 14, 15, he's fine. In the midnight, when we were done with some procedure and we were rounding on our patient, we found that patient, his GCS was 5 all of a sudden. Why? Because he was not followed at that time. People would be sleeping and even the attendants would be sleeping. If we didn't go there and check that patient would have died. Thankfully, we did the decompression and he's fine, but following those patients is very important. It will present to you at the end of the day. There is no subtlety about the brain. If you follow it, it will present to you.
Thank you, doctor. The fourth question reads, in case of increased ICP, where mannitol is unavailable, what alternative medical measures should be used to control ICP or prevent further ICP elevation in secondary brain injury?
That's a very, very good question. So, medical management of increased ICP, the first one is mannitol. But when you work in a LMIC, always you have to modify it some way. Usually, the available medication would be Lasix. If you have Lasix, you might use that, high-dose Lasix. If you have hypertonic saline, I think if you don't have mannitol, it's high likely you won't have hypertonic saline, but the options of management would be mannitol, Lasix, hypertonic saline, and elevate the head of bed. I don't know if the patient is ventilated, you can hyperventilate. That's one way of managing that. But I don't know if you don't have mannitol, it would be very difficult for you to intubate those patients and the like. But these are the options. Hypertonic saline, sometimes Lasix works, and hyperventilating those patients, and head elevation.
Okay, thank you, doctor. The fifth question reads, how do you intubate a patient with suspected C-spine injury since immobilization is difficult during intubation?
That's a very good question. So experts in this are critical care doctors, but you don't always need to move their neck to intubate. The ideal way would be to use video laryngoscopy. Do you have a video laryngoscopy? Very well. If so, you can do that. If not, there are experts who do the intubation while the patient is still immobilized. So in the OR, what we do is, for example, we're about to intubate the patient, we stabilize the patient with our own hand, and the anesthesiast would be intubating. It is difficult. I know it's not going to be easy if you don't have video laryngoscopy or things like that, but still you have to stabilize the neck in whatever way you can, usually with our hand, and then the anesthesia, they will struggle. I'm not going to lie, they will struggle, but they will intubate.
Okay, our sixth question reads, what's your primary modality of investigation for suspected cervical trauma, CT or MRI?
CT scan. MRI is, when do you use MRI is the question. CT is the first line. Whatever investigation, like trauma patient, CT is the first line. MRI would be done in patients where you suspect, for example, post-traumatic disc herniation. In patients, you're not so sure that they have ligamental injury. For example, when you're trying to decide for surgery and you want to decide, should I go anterior, should I go posterior? Those decisions. then you would use MRI. Otherwise, CT scan is the first line for trauma.
Okay, our next question reads, place of antibiotics in basal skull fracture.
This is a very controversial issue, by the way. So, in patients who there are different guidelines. So you need to have your own guideline as an institution. The guideline we use, you don't necessarily need to give antibiotics unless the patient develops meningitis. But this is a controversial issue. So have your own guideline. Some of the guidelines would say, yes, start antibiotics for all patients, but that issue now becomes antibiotic resistant bacteria and things like that. So in our guideline, we don't necessarily start antibiotics for patients who have say safely. But there are also guidelines that say start antibiotics. So it's institutional and it's a bit controversial. If you ask me, in a setup that has a higher rate of infection, it's better to start that antibiotics.
Okay, thank you, doctor. Our eighth question reads, spinal shock versus neurogenic shock after injury.
That's a very interesting question. So their pose basically is the same, but neurogenic shock, it's still talking about the blood pressure. So you have the blood pressure, patient is hypotensive and bradycardic, and it's because of the spine injury, that's your neurogenic shock. Whereas the spinal shock, it plays with the lower motor, upper motor neuron lesion type of issue. So in a patient who you would expect to have upper motor type of injury, in which they will have some sort of hyperreflexia, increased reflexes, there will be increased tone would be there. However, this patient would have lacks everything. Everything is flaccid and bulbar cavernous is also lost. So in those patients, you call them spinal shock. But the problem with this is there are some books who actually use for interchangeable. But neurogenic shock is talking about the blood pressure, but spinal shock is talking about the pattern of presentation of the spine patients. So why we care about spinal shock is you need to wait to prognosticate those patients. You need to wait for the spinal shock to be over. That's what differentiates them.
Okay, thank you. Our 9 questions reads, how long should a patient be on anticonvulsants once initiated, or when should we discontinue the anticonvulsants?
So if you started for prophylactic, if it is prophylactic, it's only for 7 days. You don't have to continue to beyond that period. But if it is a therapeutic one, a patient has seizure, and you started the anticonvulsant, it's like everybody else. You wait for patient to be seizure-free, at least for 2 years, and then you would stop it. So if it is prophylactic, 7 days, you can stop. If it is therapeutic, you follow the other guidelines as well.
Okay, our last question for the day reads, how long can we optimize the current MDT practice and improve patient care?
This is, so I had a couple of abroad experiences, and you would be surprised the amount of coherence they have. There is either, when it comes to the meetings, there is either every 2 weeks or every 1 week or every month to discuss almost on all patients that needed that MDT. For example, if you're talking about neuro-oncology, there is a neuro-oncology MDT. If you're talking about neurotrauma, there is a neurotrauma MDT, things like that. So there is a meeting. That's one thing. The other important thing, there is coherence amongst the specialties. So it takes someone to be dedicated for that. For example, if you're a critical care specialist, you would be responsible to create that MDT and basically force everyone to care about that too. But you have to train everyone. You have to tell everyone the importance of what they are doing. And once people know what they are doing is very important, and it's easy for everybody else to talk to each other, to collaborate with each other, then the MDT would be easy. The problem with as doctors, patient is a specialist. Now it's like the ego issue and things like that. And it's difficult for people to collaborate, to talk to each other. Now it's being resolved somehow, but you need to have that mentality. You need to have that mentality. We're here for the patients. Whatever works for the patient, we have to establish that. And what works is MDT. MDT works for smooth patient care. So if you have that mentality, it would work. If not, it's very difficult. I understand that.
Okay, Dr. Eyerusalem, thank you very much. I think we have addressed most of questions for the day. We would like to thank you for this session. I think the audience has enjoyed it as much as I have. They're already asking us when our next session will be on neurosurgery. So we will try to have a session very soon. As of now, we will continue to the post-webinar quiz, and after that, we'll return back to here.
Okay, the first question was, while assessing D in the ABCDE approach, you noticed one pupil is dilated and not reacting to light. This finding suggests A, raised intracranial pressure, B, hypovolemic shock, C, cervical spine injury, and D, thoracic spine injury.
So I think I have mentioned this during the presentation. So whenever there is a raised intracranial pressure that results, it will result in ankle herniation. And this ankle herniation, because of the passage of cranial nerve 3 through the incisura, it will result in compression of the cranial nerve 3. That will result in blown out pupil, which is a pupil that is dilated and not reacting to the light. So the proper result, the proper answer would be a raised intracranial pressure.
Thank you. The second question reads, when managing a patient with traumatic brain injury, the first priority is to A, check blood glucose, B, secure the airway and ensure adequate oxygenation, C, insert an IV line and start fluids, and D, do a CT scan of the head.
I think this is also straightforward. Based on the AT list guideline, we have to always start with our ABCD, and A would be airway. And I think this is straightforward.
Thank you. The third question reads, in a trauma patient who is unconscious, what should always be assumed until proven otherwise? A is the patient has a neck fracture, B, the patient has no spinal injury, C, the patient has a head bleeding, and D, the patient has internal bleeding.
So the main point of this question is for anybody who sees an unconscious patient is not to forget the cervical spine. So I know it might be a bit confusing, but whenever you see an unconscious patient, you always need to assume there is also a cervical spine fracture. And then you rule it out, then you get to move on. I understand that might be a bit confusing, but the question itself is the focus is for the neck fracture.
Okay, thank you. The fourth and final question reads, a patient with a suspected spinal injury suddenly loses sensation and movement below the waist. What should you do immediately? A is encourage them to move to check strength. B is log roll carefully while maintaining spine alignment. C is sit them up to improve comfort. And D is delay action until an X-ray is done.
I think this is also straightforward. What I wanted to emphasize with this question is always when a patient has some spine injury, you shouldn't forget to log roll them to maintain stability of the spine, whether they have a new development of this sensory loss or not. When this happens, what you want to do is evaluate them, what happened, right? But when you do evaluate them, you have to log roll when you are trying to whatever examination you want to do. The others are basically ridiculous. They don't make any sense, the answers. So I think the right answer would be log rolling them.
Okay, thank you. These were all for the post-CME quiz. So we're at the end of our session, and on behalf of Yetena Weg and the Ethiopian Medical Association, we extend our sincere appreciation to our guest speaker, Dr. Eyerusalem, for sharing her time, expertise, and commitment to improving neurotrauma care. Our session has been very engaging and informative, and it was a pleasure to have you with us. And thank you to all our participants for your engagement. We look forward to welcoming you to our upcoming sessions. Thank you.
All right, thank you.